Hello friends, today we are going to learn about in vitro fertilization. The natural process of fertilization results from the fusion of an ovum and a sperm and occurs within the fallopian tubes inside the female body. If the fertilized ovum implants within the endometrium of the uterus and continues to grow, it forms an embryo which completes development over a span of time. This process is called natural or unassisted conception. In some cases, for certain reasons, this process fails to take place normally within the female reproductive system. This process of fertilization is then simulated outside the living body and made to take place under sterile laboratory conditions and is termed as in vitro fertilization. In vitro fertilization, that is IVF, is a complex series of medical procedures used to manage the condition of infertility and assist with the conception of a child. During IVF, mature ova are collected or retrieved from the ovaries of the female and fertilized by sperm in a culture dish in the laboratory. Since this process of fertilizing the ovum with a sperm takes place in the laboratory in sterile glassware, it is said to occur in vitro, means in glass. Several scientists were successful in achieving in vitro fertilization for various animals experimentally, but successful human IVF came later. Dr. John Rock was the first to extract an intact fertilized egg. In 1959, Min Chiu Chang at the Worcester Foundation proved fertilization in vitro was capable of proceeding to a birth of a live rabbit. Chang's discovery clearly demonstrated that oocytes fertilized in vitro were capable of developing, if transferred into the uterus, could produce live young. The first pregnancy achieved through in vitro human fertilization of a human oocyte was reported in the Lancet from the Monash University team of Carl Wood, John Leeton and Ellen Tronson in 1973, although it lasted only a few days and hence was termed as biochemical pregnancy. An ectopic pregnancy was reported by Patrick Steptoe and Robert Edwards in 1976. In 1977, Steptoe and Edwards successfully carried out a pioneering conception which resulted in the birth of the world's first baby to be conceived by IVF, Louise Brown, on 25th July 1978 in Oldham General Hospital, Greater Manchester, UK. Dr. Robert Edwards and Dr. Patrick Steptoe published the first report of successful in vitro fertilization. Louise Joy Brown was the IVF baby developed in their laboratory and was popularly referred to as the world's first test tube baby. This sensational scientific feat brought hope to millions of childless, infertile couples who realized that it was now possible to achieve successful fertilization in the laboratory. Louise was 28 years old in 2006 when she had her own conception and newborn in the natural way without medical intervention. Robert Edwards was awarded the 2010 Nobel Prize in Physiology or Medicine for the development of in vitro fertilization. Carl Wood is often referred to as the father of IVF, that is in vitro fertilization, for having pioneered the use of frozen embryos. Dr. Subhash Mukhopadhyay, a physician from Kolkata, India, created the world's second and India's first child using IVF. The child Durga was born 67 days after the first IVF baby in United Kingdom. The West Bengal government denounced Dr. Subhash Mukhopadhyay's claim that he had created history. In frustration, he committed suicide in 1981. Finally, in 2005, through the efforts of Dr. T.C. Anand Kumar, the ICMR recognized his contribution and upheld his claim, although it was tragically late. Dr. Indira Hinduja was the gynecologist responsible for the birth of Harsha Chavda, India's first medically recorded IVF baby in 1986. The birth of an IVN at the state-run hospital KEM Hospital in Mumbai opened up the much-sought opportunity for treating couples in India incapable of natural reproduction. In the procedure carried out for an IVF, mature ova are retrieved from the ovaries and fertilized by sperm under sterile laboratory conditions. Then the fertilized embryo at an early stage is implanted in the uterus by medical professional. One cycle of IVF takes about 2 weeks. The IVF procedure can be done using one's own ova and the partner's sperm. In case the male is infertile and unable to produce sperm sample or semen, or the female is unable to ovulate, then donor sperm and ova from known or anonymous donor may be used following the medical, ethical and legal guidelines. In some cases, a gestational carrier, a selected female who volunteers to have the embryo implanted in her uterus may be an additional feature in the IVF procedure, and this is termed as surrogacy. When a couple has been diagnosed by the clinician as infertile, a series of tests is carried out to identify the cause of infertility. If, according to the etiology, the gynecologist can treat the partners, they may respond to treatment and conceive. However, in several cases, the problem is difficult to identify or treat, after which the couple are advised to resort to a medically assisted in vitro fertilization program. Which are the cases usually advised to do so, and when does a clinician ask a couple to undergo an IVF program depends upon the indications obtained after the test results. Generally, basic screening tests are performed on both partners at all IVF clinics with the aim of identifying the cause of infertility. Let us see the indications. IVF can be used to manage the condition or treat infertility with the patients like females with blocked or damaged fallopian tubes, male factor infertility including decreased sperm count or sperm motility, increased sperm anomalies, male factors like immunological problems, infections and erectile dysfunction, females with ovarian atresia, ovulatory disorders or premature ovarian failure unable to ovulate in a normal cycle, females who have had their fallopian tubes removed or absent congenitally, females with uterine anomalies or uterine fibroids, individuals with genetic disorder, cases of unexplained infertility where all test results appear normal and no cause can be identified. There are 5 main steps in vitro fertilization and embryo transfer process. First is ovarian hyperstimulation, where stimulation and monitoring the development of healthy ova in the ovaries by hormone administration is done. Second is oocyte retrieval, that is collection of ova. Third is sperm preparative techniques. Fourth is in vitro fusion of ova and sperm in culture medium in the laboratory and provision of an appropriate environment for fertilization and early embryo growth. And fifth is transfer of embryos into the uterus in the female primed with hormones to receive implantation. Let's discuss these steps in detail. First step, ovarian hyperstimulation. Fertility medications are prescribed to stimulate ova production. Multiple ova are desired because some ova will not develop or fertilize after retrieval. Transvaginal ultrasound is used to examine the ovaries and blood test samples are taken to monitor hormone levels. When used in conjunction with IVF, ovarian hyperstimulation may be followed by final maturation of oocytes using human chorionic gonadotropic, that is HCG hormone, or a GnRH agonist to simulate the normal hormone interplay required for development of ovarian follicles and ovulation. Ultrasound scanning is also used periodically to monitor the growth and development of the ovarian follicles so that they can be retrieved at the correct time. 3D ultrasound pictures may be taken of the multiple follicles in an ovary stimulated for IVF. IVF stimulation protocols generally involve the use of 3 types of hormone treatments. First, a medication is given to suppress the LH surge and ovulation takes place. There are 2 classes of drugs used for this: GnRH agonist, that is gonadotropin releasing hormone agonist, and GnRH antagonist. FSH product, that is follicle stimulating hormone to stimulate development of multiple ova, HCG human chorionic gonadotropic to cause final maturation of the ova. The ovaries are stimulated with the injectable FSH medications for about 7 to 12 days until multiple mature size follicles have developed. A good in vitro fertilization treatment regimen for ovarian stimulation would help to produce approximately 8 to 15 quality ova at the ova retrieval procedure. The procedure should not have adverse effect or complications of overstimulation of the ovaries. The protocols followed are standardized by each doctor individually. The standard long protocol is mainly for patients in the age range below 35 years, younger women with normal ovarian reserve. However, for the age range greater than 38 years with diminished ovarian reserve or undergoing their less than equal to 2 cycles for IVF or ICSI, short protocol, modified super long protocol or mild stimulation protocol are used. The super long protocol is chiefly used in cases with advanced endometriosis. Long protocol. The long protocol is generally administered subcutaneously, GnRH agonist 0.1 mg daily. When the desensitization was achieved daily subcutaneously, injection of recombinant FSH at a dosage of 150 to 300 IU daily can be given and continued until and including the day of triggering of final oocyte maturation. In short protocol, GnRH agonist 0.1 mg administered on day 2 of menstruation and rFSH was given on day 3 of menstruation at a dosage of 150 to 300 IU per day. In super long protocol, GnRH agonist 3.75 mg injected intramuscularly on day 2 of menstruation twice and HMG was started 20 days later after the second GnRH agonist injection. In modified super long protocol, GnRH agonist 1.875 mg injected intramuscularly in mid-luteal phase twice and HMG was started 16 days later after the second GnRH agonist injection. In mild stimulation protocol, FSH-like molecules such as human menopausal gonadotropin HMG are given on day 3 of menstruation to stimulate folliculogenesis. When at least 3 follicles reach 17 mm, human chorionic gonadotropin is then administered. Oocyte retrieval is scheduled approximately 36 hours after LH or HCG injection. Progesterone in oil may be used for luteal support at a dose of 60 mg per day. Pregnancy is then confirmed by monitoring serum beta HCG or by clinical examination. Looking to natural cycles in vitro fertilization, when the IVF treatment regime is done without hormone therapy or any medication for ovarian hyperstimulation, but use of drugs only for ovulation suppression, it is considered that it works on natural cycle. Hence, IVF is done including ovarian hyperstimulation with gonadotropins but with a GnRH antagonist protocol, so that the cycle initiates from natural mechanisms. This is referred to as natural cycle IVF. IVF using no drugs for ovarian hyperstimulation was the method for the conception of Louise Brown. This method is employed when the patient wants to avoid taking ovarian stimulating drugs to avoid the associated side effects. The estimated live birth rate is low, approximately 1.3% per IVF cycle, using no hyperstimulation drugs for women aged between 40 to 42 years. Mild IVF is a method where a small dose of ovarian stimulating drugs are used for a short duration during a female's natural cycle aimed at producing 2 to 7 ova and creating healthy embryos. This method appears to be an advance in the field to reduce complications and side effects for women, and it is aimed at quality, not quantity of ova and embryos. Step 2 is ova retrieval, where ova are retrieved through a minor surgical procedure that uses ultrasound imaging. to guide a hollow needle through the pelvic cavity to collect the newly released ova. Medication is provided to reduce and remove potential discomfort. Size criteria of follicles for retrieval is when the follicles are matured, that is determined by ultrasound measurements of follicle size and hormone measurements. The ova aspiration procedure is done to collect the ova. The optimum size for considering the ova as mature is between 15 to 20 mm diameter. Anesthesia is used for ova retrieval, and anesthesia is administered intravenously so that the patient does not feel pain during the ova retrieval procedure. Conscious sedation, general anesthesia, and even local anesthesia can be used for this procedure. Ova retrieval procedure, a needle is passed through the top of the vagina under ultrasound guidance to reach in close proximity to the ovary and follicles. The fluid in the follicles is aspirated through the needle, and the ova, which has just been ovulated, detach from the follicle wall and are drawn out or aspirated from the ovary. The procedure usually takes about 10 to 20 minutes. Transvaginal oocyte retrieval, that is TVOR, also referred to as oocyte retrieval OCR, or even simply ova collection, is a technique used in order to remove maturing oocytes from the ovary of the female. Transvaginal oocyte retrieval is often technically referred to as transvaginal ovum retrieval when the oocytes have matured into ova as required for an IVF. Under ultrasound guidance, a needle is inserted through the vaginal wall and into an ovarian follicle, taking care not to injure organs located between the vaginal wall and the ovary. The other end of the needle is attached to a suction device with a facility to collect the ova in culture media. Once the follicle is aspirated, suction is gently applied to aspirate follicular fluid, and with it cellular material is drawn up, including the oocyte. The follicular fluid is delivered to a technician in the IVF laboratory to identify, examine and quantify the ova. A small amount of follicular fluid is also retrieved along with the ova. The fluid is combined with sterile culture media in the aspiration cannula itself. The ova is then passed to the IVF lab where the ova are identified, rinsed in Ham's F10 culture media and placed in small drops in sterile culture dishes. The dishes with the ova are then kept in specialized IVF incubators under carefully controlled environmental conditions of pH, 5% CO2 and buffered medium. In ova retrieval recovery, when all of the follicles have been aspirated, the patient is monitored closely for about an hour. Recovery is usually straightforward with mild to moderate cramps experienced for a few hours. However, there is no serious after effects of ovum retrieval. In ova retrieval success, most doctors retrieve about 8 to 12 ova on the average at ova retrieval. Age has an effect on the number of ova produced, ovulated and collected. It is possible to retrieve more follicles if the patient is younger in age. In ova preparation, in the laboratory, the identified ova are separated from their surrounding cells and prepared for fertilization. An oocyte selection may be performed prior to fertilization to select ova which are mature with a coarse, granular texture of ooplasm and with the polar body extruded. Such ova would have optimal chances of successful pregnancy. Moving on to step 3, sperm preparation. As the oocytes are being retrieved simultaneously, the semen of the male partner is to be collected for obtaining the spermatozoa. This sample is collected from the male under sterile conditions after a period of 3 to 5 days abstinence. Semen analysis is carried out to check the quantity and quality of the sample. A buffer is used to wash sample to remove dead, non-motile sperm, leukocytes or bacteria, and a good quality fraction is collected using standard sperm preparation techniques. Before the sperm gain full potential to fertilize the ovum in vitro, they have to undergo a process of capacitation. In this process, the sperms are incubated in a medium containing a carrier of calcium, that is calcium ionophore 23187. This transport of calcium across the sperm membrane is an essential prerequisite for the acrosome reaction, a reaction which is needed for the sperm to penetrate the investments of the oocytes. Hence, the process of capacitation which normally takes place in the uterus of the female is to be carried out under laboratory conditions for an IVF to take place. The sperm are thus prepared for combining with the ova in vitro. Step 4 is co-incubation. In a process called insemination, the sperm and ova are mixed together and incubated in a laboratory to allow fertilization. The collected, washed, prepared sperm is then placed together with the ova in culture media in the laboratory, that is in vitro, about 4 hours after ova retrieval for the process by which the sperm penetrate the ovum. If fertilization does not occur unaided, then the final barrier to sperm penetration is overcome and a single sperm is injected individually directly into the cytoplasm of the ova. This injection process is called intracytoplasmic sperm insemination, that is ICSI. The sperm and the ova are incubated together at a ratio of about 75,000:1 in a culture media in order for the actual fertilization to take place. A duration of this co-incubation of about 1 to 4 hours results in significantly higher pregnancy rates than 16 to 24 hours. In most cases, the ova will be fertilized during co-incubation and will show 2 pronuclei. The fertilized ova is passed to a special growth medium and left for about 48 hours until the zygote divides and form 6 to 8 cells. In gamete intrafallopian transfer, ova are placed in one of the fallopian tubes along with the sperm. This allows fertilization to take place inside the female body in the natural microenvironment. Therefore, this variation is actually in vivo fertilization, not an in vitro fertilization. The following morning, the ova are checked for evidence of fertilization under the inverted microscope. If the zygote shows the presence of 2 pronuclei, it is taken as an indication of positive fertilization. The embryos are cultured in the IVF lab for 2 to 5 or more days before one or more is put into the uterus by the embryo transfer procedure. 14 days after ova retrieval, evidence the test for HCG, the pregnancy test, is carried out to confirm. In embryo culture, the main durations of embryo culture are until cleavage stage, that is day 2 to 4 after co-incubation, or the blastocyst stage, that is day 5 or 6 after co-incubation. Embryo culture until the blastocyst stage confers a significant increase in live rate per embryo transfer, but also confers a decreased number of embryos available for transfer and embryo cryopreservation. So, the cumulative clinical pregnancy rate are increased with cleavage stage transfer. In embryo selection, laboratories have developed grading methods to evaluate ovum and embryo quality. In order to optimize pregnancy rates, there is significant evidence that a morphological scoring system is the best strategy for selection of embryos. Moving on to step 5, which is embryo transfer, the embryos are usually transferred into the woman's uterus 3 to 5 days following ova retrieval and fertilization. A catheter or small tube is inserted into the uterus to transfer the embryos. This procedure is generally painless, but some may experience mild abdominal cramps. Embryos are checked by the embryologist based on the amount of cells, evenness of growth, and degree of fragmentation. The number to be transferred depends on the number available, the age of the woman, and other health and diagnostic factors. The embryos observed to be the most superior in quality are transferred to the patient's uterus through a thin plastic catheter which passes through the vagina and cervix. Several embryos may be passed into the uterus to improve chances of implantation and pregnancy. If the procedure is successful, implantation typically occurs around 6 to 10 days following ova retrieval. Adjunctive medication. After the embryos are transferred, it is important that the uterus accept the blastocyst, hatching should take place and new embryo should implant within the trophoblast. For this purpose, the female should be primed with the correct levels of hormones so that she is physiologically and endocrinologically ready to carry an embryo. Luteal support is the administration of medication, generally progesterone or GnRH agonist, to increase the success rate of implantation and early embryogenesis, thereby complementing and or supporting the function of the corpus luteum. Seminal fluid contains several proteins that interact with epithelial cells of cervix and uterus, inducing active gestational immune tolerance. There are significantly improved outcomes when women are exposed to seminal plasma around the time of oocyte retrieval. The side effects of in vitro fertilization. The side effects are few and most patients can resume normal activities the following day. Some side effects after IVF may include passing a small amount of fluid that is maybe clear or blood tinged after the procedure, mild abdominal cramping and bloating, constipation, breast tenderness. The complications include, there are very few complications that are encountered. They may include certain stages of discomfort, heavy vaginal bleeding, pelvic pain, which may be related to the administration of excessive hormones during ovarian hyperstimulation, blood in the urine, and a fever over 100.5 degree Fahrenheit or 38 degrees centigrades. Risks associated with in vitro fertilization. Risks associated with in vitro fertilization are: hormone administration can have various side effects including headaches, depression, abdominal pain, hot flashes and bloating. Although it is rare, fertility medications may cause ovarian hyperstimulation syndrome, that is OHSS. Symptoms of OHSS may include abdominal pain or a feeling of being bloated. More severe symptoms include nausea or vomiting, decreased urinary frequency, shortness of breath, faintness, severe stomach pains and bloating. Often, a patient may experience weight gain within 3 to 5 days. Additional risks of IVF includes ova retrieval may carry risks of bleeding, infection and damage to the bowel or bladder. The chance of multiple pregnancy is increased with the use of fertility treatment, since few embryos are implanted to increase the chances of implantation. There are additional risks and concerns related to multiple during pregnancy, including the increased risk of premature delivery and low birth weight. Assisted reproductive technology ART involves a significant physical, financial and emotional commitment on the part of a couple. Psychological stress and emotional problems are common, especially if in vitro fertilization is unsuccessful. IVF is expensive and the associated cost of medication and healthcare may prove to be a financial burden. Success rates for in vitro fertilization in clinics depends on a number of factors including reproductive history, maternal age, cause of infertility, addictions and lifestyle factors. It is also important to understand that pregnancy rates are not same as live birth rate. A positive implantation may not necessarily complete the embryonic development due to certain other factors. The live birth rate for each IVF cycle started is approximately 41 to 43% for women under age 35, 33 to 36% for women ages 35 to 37, 23 to 27% for women ages 38 to 40 and a low success rate of 13 to 18% for women over 40 years of age. The number of embryos created or transferred typically depends on the number of ova collected and maternal age. As the rate of implantation decreases as women age, it may be necessary to implant more ova depending on the age to increase the likelihood of implantation. However, the greater the number of ova transferred, the greater the chances of having a multiple pregnancy. Ethical and legal issues related with IVF. Since an IVF deals with the unborn, social, ethical and legal issues are as important as medical concerns in a country such as ours with great emphasis on childbearing and male offspring's proclivities. in vitro fertilization programs could be the source of added social trauma and unethical outcomes if not monitored. Certain legal and ethical issues that are regulated include the use of donor sperm and eggs. For example, anonymity is guaranteed in law for donors in some countries and may prove to be important condition when the child matures and wishes to identify his biological parents. Doctors have often been implicated in the use of donor sperm ova to increase success rates in IVF without the knowledge or consent of the patients. The use and payment of surrogates. Commercial surrogacy is banned in many countries, although it is legal in India. Newer laws may be implemented to restrict foreign couples from unduly exploiting this facility. The in vitro development period allowed for embryos. In many countries, embryos are allowed to develop for several days to allow selection of the healthiest candidates, but in others, only early embryos can be implanted. The selection process for embryos, including sex selection and genetic screening. For example, pre-implantation genetic diagnosis, that is PGD, is banned in some countries but allowed under strict regulation in others. This could be important if used only to screen for genetic abnormalities, but if misused the purpose of sex determination, it could lead to disastrous consequences. The maximum number of embryos that can be transferred, for example, many countries have strict single embryo transfer policies, while others will leave the number of embryos implanted up to the discretion of the fertility specialist. However, it has been realized that strict monitoring is required to restrict the creation of embryos for research or testing purposes. The maximum storage time for frozen embryos. Spain and Canada allow unlimited storage, whereas Brazil has limit of just 3 years. The use of frozen sperm or embryos after the death of partner. For example, in Iceland, frozen sperms must be destroyed when the male partner dies. But in Belgium and Netherlands, it can be retained with written permission for future use in fertility treatment. The legal issues in our country need revision and strict implementation. These legal and ethical issues are highly complex and vary widely. Ethical issues can be even more complicated than legal ones. For many people, the act of conception is holy and should not be interfered with in any way. For others, having a baby is the most important thing, and the methods involved do not worry them. The number of embryos created, handled, and discarded is an important ethical issue. Stem cell researchers should weigh the ethical and legal specifics before availing of extra embryos for research. Current status of IVF in India. Today, India is one of the leading countries equipped with state-of-the-art of technology and advanced medical expertise. Society is to become more open and receptive to the idea of in vitro fertilization. IVF technologies is a major source of medical tourism, and the choice of surrogacy by foreign couples is increasing. Success rates too have been increasing, and almost every infertility clinic can offer ICSI facilities at competitive costs.
To summarize at the end, in vitro fertilization. If the natural process of fertilization fails, then fertilization is simulated outside the body under sterile conditions in laboratory. Mature ova are fertilized by sperm in culture, and hence procedure is termed as in vitro fertilization. The first successful in vitro fertilization was carried out in the laboratory of Dr. Robert Edwards and Dr. Patrick Steptoe in 1978. There are 5 main steps in vitro fertilization and embryo transfer, that are ovarian hyperstimulation, oocyte retrieval, sperm preparation techniques, in vitro fusion of gametes using sterile and optimal laboratory conditions, and transfer of embryo into the uterus. Medical, ethical and legal guidelines are to be followed. Couples to undergo IVF go through basic screening techniques. Cases of infertility like unexplained infertility, ovulatory disorders, congenital anomalies of the system, ejaculatory failures and genetic disorders are advised to opt for IVF. There are a few side effects of IVF like headache, cramping, chances of infection, multiple pregnancies, financial and emotional stress on couples. The success rate of IVF also depends on certain factors like age of the couple and causes of infertility. Hence, in the field of reproductive biology, IVF can be considered as a potential technique in the management of infertility, thereby providing assisted conception to infertile couples. Thank you.